how you manage the logistics on the environment, the lighting condition, etc. Now this will expand that you manage the airways in car parks or stadiums or God knows where. So think about that, why the environment is a challenge and how you control the environment. The second is the patient. Your patient is usually, as we said, have some sort of respiratory failure and cardiovascular instability. Their pharmacokinetics and dynamics are not the same as the patient for elective airway management. They are super sensitive to medications that use for induction and maintenance. They have either hypoxic or hypercapnic respiratory failure or both of them. Their functional residual capacity is hugely reduced. They are at respiration risk. As somebody alluded recently in lots of publication, cricoid is dead. So do you still apply cricoid? What's the role of cricoid pressure in current medicine? The high-risk patient with intracranial pathology, acute coronary syndrome, and sickle cell disease, they are all risk factors for your intubation and airway management during the time of induction. And this all amounts to cardiac arrest and significant incidents during airway management. Your team is different from the operating room team. In the operating room or operating theater complex, there are lots of anesthetists around. You are stuck, you call for help. 2 minutes, you have senior anesthetist around that can give you some insight, at least can relieve you from the tension and pressure. You have an operating room assistant or technician. The RRT team or the rapid response, most of the time is inconsistent. You know, today I have a senior nurse or somebody that I worked with before. The following day, God knows what, who's with me in the team. Somebody that I have never seen in the last 10 months. The experience of the team is inconsistent. And how often they get called for this airway management patients and calls. Again, the non-technical skills of the personnel is inconsistent. We'll come to that. So if you haven't seen the NAP4, if you haven't read the NAP4, you have to go and take a look at that. And this is the original paper by Tim Cook and colleagues from the UK. And it's published in the PGA almost over a decade ago. And as I said, it looked at all complications from airway management in the elective and emergency situation in the UK for over a year. The summary, in the ICU, in the critical care situation, 61% of events of complication led to death or persistent neurological damage. That's a very high incidence. And in the emergency department, the incidence was 31%. So please consider that and remember the figures. Airway incidents in the ICU and the ED were more likely than those during anesthesia to occur out of hours. As I said, typically 2 o'clock in the morning, typically on a weekend, and that's because they were managed by less experienced doctors and led to permanent damage. And please, if you haven't got a capnography or an end-tidal CO2, make sure that you always use that during induction of anesthesia and management of the airway. If you haven't got guidelines on your trolleys in your units, you must have one. But remember, they are only there to guide you, not to tell you exactly what to do. And always have a plan, and the plan is detailed as A, B, C, and D. And there is a very famous quote that if you fail to plan, you plan to fail. And your plan is not a tool or device, it's just a plan. So what do we have so far? We have this, which is a very nice piece of work. And remember, this is tracheal intubation for the critically ill. This is not for elective intubation of the surgical patient. And this is a nice piece of work. And as you see, it's a combination of Critical Care Society of the UK, the Difficult Airway Society, the FICM, and the Royal College of Anaesthetists. And the emphasis here is on 2 things. For me, there are 2 magic numbers. The first magic number is this. On first failure, you call for help. So if you remember anything from this slide, remember 2 numbers, 1 and 3. You fail once, you call for help. You don't wait for longer. And you have only 3 attempts, maximum 3 attempts to succeed. So if you fail at the first attempt, you call for help. You don't wait to take a second look and third look and then call for help. No. At the first failure, you call for help. And at the third attempt, if you not succeed, you move on. The second thing here, and that's the major difference between the critically ill and non-critically ill, is that the plan B and C are combined into the rescue oxygenation by the supraglottic airway and the face mask. So we don't have this separation between plan B and C as we have in the elective intubation for the elective surgical patient. And as you see again on the right side of the screen, the fauna or the front of the neck, there is a huge emphasis on that. So here, after you fail once, you call for help and you get the front of the neck device out of the box, out of the drawer, before your eyes. Again, if you don't succeed, you proceed for that. And that's why we need to practice that. And finally, you proceed for that, or you get one more attempt by a very senior or an airway expert. So the emphasis again on not wasting much time. The front of the neck, we'll talk about that, how you do that. It's a very simple procedure, and now it's a cut, a bougie, a tube, 3 steps, no faffing, no complex surgical procedure, and it's a scalpel cricothyroidotomy. And again, why scalpel cricothyroidotomy? I'll go back to the NAP4, because from the NAP4, we learned that the scalpel cricothyroidotomy is associated with a better outcome, more success, and less complication. It saves lives. I know we are, as anesthetist and intensivist, we are used to the Seldinger technique, needle, guide wire, and cannula. But the scalpel cricothyroidotomy is proved to save lives. And this is as simple as that. All you need is a scalpel, a bougie, and a small culture tube. If you haven't seen this, this is the ASA, American Society of Anesthesiologists, 2022 guidelines, published January this year. So it's fresh from the press. Again, this is not for critically ill patients. This is for elective intubation. Akin to the other guidelines by the British and the European counterparts, it's 3 parts. It emphasizes pre-airway management, decision-making tool. The Americans, and it's not just American, this is produced by 15 airway societies, not just the Americans. And it emphasizes more for the first time on awake airway management, okay? Versus airway management with induction of anesthesia. Now the thinking is more towards keeping the patient awake if you suspect the difficulty. So we need to keep the patient more awake, stop giving the anesthetic induction agent if we suspect difficult laryngoscopy, prefer awake. If you suspect difficult ventilation, large neck, huge beard, any difficulty, prefer awake. If you suspect significantly increased risk of aspiration, prefer awake. Risk of rapid desaturation, prefer awake. And this is all quantified by numbers and some diagnostic data. So that's for the awake. Again, the awake strategy and the awake techniques are detailed in the paper. And there is more emphasis here on the emergency, and the only thing added to the airway guideline for the first time is ECMO. And this is of interest for me because I'm one of the ECMologists in Hamad. So the new guidelines for 2020 from the ASA, even for the elective, emphasizes more on awake intubation, and that's something Marcus may allude to in his fiber optic lecture, and the awake airway management, how to establish awake tracheal intubation, and for emergencies, the use of ECMO. And this is published in 2022. So now I went with you through this introduction. So how we do this? The key to this is by A, prepare, B, practice, rehearse. If you don't do this often, you have to use alternative training methods like simulation. And in reality, please call for help early. An example, again, associated with the guidelines is this checklist. If you don't have a checklist, please have one. So part 1, prepare your patient. We talked about preparation. So part 1 is patient preparation. Anatomical resuscitation of the patient, physiological resuscitation of the patient is important. You have to have good IV access that's working and functioning. And to make your life easy, again, go back to the checklist. Do I have a reliable IV access? If I don't have IV access, you have to have an intraosseous access. And that's quite doable now. Okay? Access, fluid, bristles, oxygen position. Again, definition of a difficult airway has different textbook definitions. That could be the one that's difficult to maintain open, difficult to back valve mask, difficult to ventilate, difficult to oxygenate, cannot intubate, cannot ventilate, cannot intubate, cannot oxygenate. So any of these is a definition for difficulty. Assessment, All of us know about all these scoring systems like the lemon, like Ganzuri on the left-hand side, like the Makoka score. Just know one and apply one. You don't have to know all of them. Why? Because not a single scoring system is proved to be 100% correct. Okay, sensitivity and specificity of these scoring system range between 70 to 80%. So not a single one is absolutely correct. Maintain a good position of your patient. We all know about that. Line of sight has to maintain otopharyngeal laryngeal axis straight. So sniffing the morning position, use a ramp, whatever, especially in obese patients, that you have to get the tragus of the ear at level of the suprasternal notch. And this is the idea. Okay? So you get the patient in this position, makes your life easier. Reoxygenation or denitrogenation is important. Okay? You have to maintain the FiO2, not the FiO2, but the expired FiO2. You have to wash out all the nitrogen in the lungs and replace it with the 100% oxygen. Take your time as much as you can and always reoxygenate your patient. Do not assume that the patient is reoxygenated. Classic teaching says that bare minimum is 3 vital capacity breaths, but now we use more of high flow nasal cannula, CPAP or BiPAP for good 3-5 minutes. The way I do it, once I'm called to get a patient intubated in emergency, I stick a high flow nasal cannula or put the CPAP or BiPAP on them whilst I'm gathering the team, collecting and preparing the medications. The second is get your equipment ready. Equipments are a vast array of things. That's our devices, monitors, medications, airway trolley, and my advice is this has to be standardized across the whole organization. Everywhere are the same. We had this in the old days, and now we have this, which is color-coded, easy to use, and maintains your lifeline equipment in an easy way. Another suggested, which has your plans detailed outside, and this is when you rehearse your plan with the team. Okay, I'm going to intubate this gentleman or this lady coming with respiratory failure. My plan A is intubation. For that, I'm going to use this blade, this tube, in this order. If I fail, I'm going to ask for help from next door. I'm going to go to plan B, which is such and such in the second drawer, which includes so and so, and move on. Your medications should include something to induce sleep, ensure that your patient is not in pain and suffering, and always use a muscle relaxant and use adequate doses and make sure that you follow the kinetics and dynamics. I'm not going to talk too much about medications, but the concept of ketofol is quite an interesting principle because maintenance of adequate blood pressure is reassuring. And the last thing is that you want is to see a drop in blood pressure. Ketamine is a very good drug for patients with cardiovascular instability. Even with a raised ICB, there is good evidence that it doesn't cause harm with a raised ICB. As I said, analgesia is a must. It has a synergistic effect with hypnotics, and most of them are hemodynamic stable. Don't be generous with them. Fentanyl is the most commonly used. Muscle relaxation is a must no matter what, except in few situations. Don't use saxamethonium with a patient with burns. Don't use saxamethonium with a patient with raised ICB. There is a big shift towards the use of prochloronium for most, if not all cases of rapid sequence induction outside the operating room. And the advantage is that you have a good antidote immediately available for that. Other medications that you have to hand are for the treatment of hypotension and cardiac arrest. As I said, cricoid pressure is becoming less fashionable, out of the window. Be aware that all you need is equal to 3 kilograms in weight. Overdoing it is bad because it can deviate the airway and make intubation very difficult and challenging. And if you are in trouble, the priority is to establish the airway. So if the view is difficult and you are the laryngoscopist, just have the ability or take the liberty to ask your assistant to remove the cricoid and get the airway sorted first. That's more important. There are two ways of induction of anesthesia. This is the classic or traditional controlled in theater. There is the rapid when the aspiration risk is there. There is the delayed and there is the awake. And it all depends on how you administer your medications and the sequence of that. And that's a totally different tool. Prepare your team, and this is what I call psychological resuscitation. We talked about anatomical resuscitation, physiological resuscitation. Your team needs psychological resuscitation. If you are the team leader and you are shaky and you are not clear and you are mumbling and your plan is not clear, believe me, your team will not be as confident and as in control of the situation as you are. So prepare your team. Make sure that your plan is clear. Make sure that they understand you and your language is clear. There is lots going on. There is lots of actions happening. There is lots of over talking, and they are very anxious. They want to save this patient. The non-technical anesthetic skills have been shown to improve team performance and improve outcome. And that's the leadership, assertiveness, decisiveness. Remember, time is of the essence. And one way I was taught as an SHO many years ago in England to do this, as I hold my laryngoscope, I hold my breath. If I don't get the tube whilst I'm holding my breath, the patient will be desaturated. So the clock is ticking. Be aware of the time. You also have to be aware of the time. You have to have somebody looking at the clock and reminding you that a minute has passed and the airway is not secure. Unless you are aware of the time, the patient will be lost. This is again some guidance for you. It depends on the team members around, how many team members are there. You have to have some control of the situation. As a team leader, if you are 4, 5, or 6, just be aware that how you distribute them to make the most out of your team during this time. So this is again just as a guidance, and you can tailor this to the situation. This is before COVID, and this is during COVID. And thank God now the COVID is not as bad as it was. Again, team leader is important, overseeing the whole situation and guiding people with clear instruction and making sure that the plan and the checklist is followed. Non-technical skills, the cognitive skills, the situational awareness, and if you haven't seen or you haven't watched the videos from the Elaine Bromley case, please go and Google it. And there is a lot of learning from that case about those simple rules about being goal-focused. Everyone was focused on getting the tube between the vocal cords and not about getting the whole patient in a good shape with a reasonable oxygenation to stay alive. And for getting the tube between the vocal cords, we lost the patient. So we have to be aware of the bigger picture. The team leader has to be there. The team leader has to lead the team to safety and maintain the patient alive. So the non-technical skills are as important as the technical skills. We have to teach our juniors how to do that in the airway management. Prepare for difficulty, and this is the last part. And before you start in preparation of the difficulty, you have to rehearse with the team and always think, can we wake this patient up if we fail to intubate? Unfortunately, in ICU, the answer is no in 90% of the cases, because the patient is about to have a cardiac arrest. They are very hypoxic, they are in septic shock or cardiogenic shock or mixed shock, and the only way to keep them alive is by intubation and mechanical ventilation and other interventions like ECMO, etc. So, but you have to answer the question, okay? And rehearse your plan and say, my plan A is 1, 2, 3, 4, B, etc. Anyone has comments or concern, and one last overall view, just go through everything before you proceed. Now we're going to do a quick review about device selection. There's a lot of device selection in the market. I'm not going to take too much of your time because I'm aware that we nearly half an hour into this. Video laryngoscopy in critical care. There has been about 9 studies, 3,000 patients involved. There is a summary of this. And the meta-analysis published a few years ago, there is a small signal that's in favor of video laryngoscopy, and the guidelines by Higgs et al. In 3 years ago, it says that the video laryngoscopy should be available and considered. So that's, again, our primary tool at the moment because it has some advantages compared to the direct laryngoscopy. However, it's not mandatory at the moment. In the crisis, I would advise use the things that you are 100% familiar with, that you are guaranteed to be successful with. That's my advice to the juniors. However, we have the video laryngoscopy available. Front of the neck access, nowadays it's more simple and quick because it's standardized across the whole organization. And the needle, as we said, is less effective and less successful. All airway trolleys must have a kit. It's a very rare procedure. I have done it once in 24 years of practice, alhamdulillah. And you should provide training to your team on a regular basis. So we have the mannequin and we practice maybe 3-4 times a year. And you should do it early rather than later when the patient is difficult to manage. It's not a tracheostomy and not jet ventilation. And the standard is cut bougie, ETT, transverse cut, advanced bougie, small, cuff the tube 5 or 6. The Voltex is a very simple and very intuitive approach to airway management in the critically ill by a group of Australia and New Zealand. Take a look at that. And it has 3 lifeline approaches to maintain life, which is maintaining oxygenation by 3 simple devices, a face mask, a supraglottic or tracheal tube. And the idea is to keep your patient in the green zone by 3 simple attempts. You have to stay in the green zone. And this is a simple explanation of that. And it has this fantastic emergency cognitive tool. I advise just go and take a look at that simple intuitive airway management cognitive tool. And they have the checklist. So one word of advice for managers and leaders, you have to have some key performance indicators for your department for critical airway management. And this is again about risk management and maintenance of records. So success rate, time to tracheal intubation and number of attempts, safety of your intubation as a department, complications, how prevalence of desaturation, instability, injury, mortality, modifiable factors in terms of patients, practitioner, drugs, techniques, and devices. Remember your goals of airway management: oxygenation, maintenance, hemodynamic stability, patient comfort, prevention of complications, blunting airway reflexes, and intubation conditions. These are the main airway management goals. Some take-home messages that critically ill patients are difficult airway by definition. Any critically ill patients, any unstable patient out of theater is a difficult airway. They will desaturate, they will have some sort of cardiovascular collapse, cardiac arrest, and brain damage are not uncommon. Before you start, prepare your patient, prepare your equipment, team, and be ready for difficulty. You will have some sort of difficulty and have plans, not a plan. Vocalize, verbalize your plan loudly and clearly. And if you fail to plan, you are planning to fail. You must have a checklist that's personalized for the patient. So there is a generic checklist, and for this particular lady or gentleman, there is a touch. There is an extra bit in the checklist that's peculiar for this. You must have a standardized airway trolley across your organization. You must provide structured training for all your trainees in anesthesia and critical care. You must audit your practice. You have to have some simulation training, high fidelity, regular basis. In your emergency, call for help early and loudly. Don't be shy. Your tool is not a plan. Your video laryngoscopy, your intubating laryngoscope is a tool. It's not your plan. Use what you know and you do best, and don't delay the front of the neck access. With this, I conclude, and I thank you and apologize for taking a little bit too long than I should. Thank you.
That's great. Thank you, Dr. Labib. That was an amazing presentation. I would keep going and listening to you. So meanwhile, like we've had in chat, lots of greetings from Saudi Arabia, from Oman. We had greetings personally to you from Dr. Alia, from Bahrain as well. We've got I've seen some raising hands. Let me double check. Yeah. You can talk if you're on mute yourself.
Yep. Well, the first question about why not muscle relaxants with burn. I meant don't use succinylcholine or succinylcholine with patients with denervation injuries and burns, because there is the hyperkalemia thing. So patients with spinal cord injury, bed-bound patients, any patient with risk of hyperkalemia, when you give them succinylcholine or succinylcholine, they will have significant hyperkalemia and cardiac arrest. That's the only thing that against succinylcholine in this. But you can use rocuronium, for example, for a rapid sequence induction in those patients. I hope this answers your question. Is there a video showing the 3-step emergency intubation from Kwasi Abu Zinda, what do you mean by the three-step emergency intubation? Can you please elaborate?
Yeah, meanwhile, there's, a third one. Yeah.
Blade, bougie, and tube. So, yeah, I can explain that. So, I'll go back to the slide here. So, the three steps are, and if you decided to go for the FONA, so you maintain your oxygenation and extend the neck, ideally before you start, and this is what I do in patients with difficult necks, I identify the cricothyroid membrane and I draw a line with my pen. I say, this is where I'm going to go. And if I have the luxury and time, I use the ultrasound as well and identify the membrane. You do a transverse cut in the membrane with your blade, and the bevel or the blade facing downwards, not upwards. So you avoid the cut to go through the cricoid itself. So a transverse cut, about 1.5 to 2 centimeter here, blade facing down. You insert the bougie next to the blade. Don't remove the blade at this stage. Okay, you just pass the bougie alongside your blade or scalpel. Okay, all you need is about 10 centimeter of the bougie inside the airway because you are below the vocal folds. At this stage, your assistant will remove the blade, you hold the bougie. You railroad the tube over the bougie, lubricate it, you hold the tube, your assistant removes the bougie, inflate, entitle CO2, ventilate. If you practice this on a mannequin, you will find yourself doing this in about 30 seconds to 1 minute. It's as simple as that. Cut, rotate the blade, bougie next to the blade, blade out, tube in, bougie out. I hope that's okay.
Yeah, so there's another question.
Video are usually bulky and sometimes difficult to insert with a small mouth operator. What's your experience? My experience, I don't use the commercial, but there is modern devices. There are pocket devices like the McGrath, for example. They are very, very small. There is the size 3 blades. For me, I've used them with an inter-incisor distance of about 2 centimeters. I didn't have a problem with that. Nabil, who is the one you would suggest to be team leader for the difficult airway outside the operating room, intensivist or anesthesia? That's a tricky one, Nabil. The most experienced, obviously, and the one who has been team leader before and has the capability and the skills to do that.
We have additional questions in chat as well. There was in difficult, in difficult airway, just coming, still we have to use muscle relaxant.
Of course.
Okay.
So there are options. As I said, the ASA is moving towards more awake intubations. So we have this gentleman from Cleveland Clinic, and he's a brilliant anesthetist, intensivist, and he described his his interest in doing this. So he opts more for using awake intubation, either by fiber optic or video laryngoscopy for patients who are deemed very, very challenging to intubate. So if his experience, this is not mine, I do very few of these. If the patient is anatomically very difficult or known to be very difficult to intubate under anesthesia, he used lots of topical anesthetic. He advanced his video laryngoscopy and do awake intubation without any sedation or muscle relaxant, unless, this is the tube in. Once the tube is in, induction of anesthesia, like, in theater. So that's a totally different approach to the classic approach. And his argument is, this is a critically ill patient with unstable cardiovascular and respiratory system. If I put them to sleep and they have an anatomically difficult, challenging, and physiologically challenging airway, they will arrest and die. So he uses this alternative technique, which I'm not sure if there is any sound scientific evidence for it, but this is anecdotal and personal experience.
Thank you. There is another one. So you're still using ketamine in shocked patient, given the risk of direct myocardial depressant effects of ketamine?
I use a lot of ketamine, 2 milligrams per kilo on most of ICU patients nowadays.
There's another one. You're experiencing pediatric difficult airway management. Any suggestions for best approach?
I'm not a pediatrician, I'm afraid.
And there is another one coming. Thanks, dear Prof, for your fantastic presentation. Please, regarding the post-COVID cases presented with respiratory issues, found like narrowing needed reconstruction. What's the first step for airway management? Are you planned for a tracheostomy? Thanks.
Yes, so the first step we do regular nasendoscopy for them. So we take a good look with the nasendoscopy and assess where the difficulty is, because we have been surprised many times before that we deal with them as a normal patient, that they have significant stenosis. And if we see there is a supraglottic issue that needs a different pathway, subglottic or lower airway, we refer them to thoracic surgery for elective trachea reconstruction.
Thank you. And there is another one. What's the sequence of medications to administer in awake intubation, and what meds are preferred?
It depends if you are doing, again, I think Dr. Kennedy will allude to that, because that's the medications used for dryness of the secretions. For example, if you use glycopyrrolate or atropine, that can have some effects like tachycardia, dryness of the secretion. If you use lignocaine, how much lignocaine do you use? If you use sedation like remifentanil and the impact of that on chest rigidity, bradycardia, cardiovascular effects. So these are the classic remedies used for awake fiber optic intubation or awake bronchoscopy. So I believe Dr. Kennedy will allude to that. I'll leave that to the expert.
There's another one coming also. Do you recommend any specific approach for cuff leak from ETT track tube?
Do you mean when they are on intensive care after prolonged intubation? That's the cuff leak test, or?
Yes.
Right. Okay. So this is the typical patient who has been on a ventilator for a little while, and we suspect they have laryngeal edema. So typically we deflate the cuff and we check for a cuff leak of at least 15 to 20% to make sure that they are safe to extubate. And that's again another topic for Boston Scientific and the Saudi Critical Care, difficulty extubation and predictors of difficult extubation. And that's another intriguing area of critical care practice. Dr. Alia might be interested in that. So the cuff leak and other predictors of difficult extubation, and the guidelines for difficult extubation are out there also recently. So Tharwat, we do this for patients who are difficult to intubate or have difficult airway because we would like to make sure that before we take the tube, we are in a safe area to reinsert the tube if we have to. B, after prolonged intubation, that the airway doesn't have any significant changes, especially laryngeal edema or damage, that will make re-intubation difficult. So we do our cuff leak. We typically look for 10-15% of the exhale tidal volume to be lost with the cuff leak to ensure that there is enough room and no damage. If the cuff leak is positive, i.e. there is a cuff leak, we are safe. If there isn't, there are two ways. You wait for the laryngeal edema to settle, you do an nasendoscopy, or you take a look around the tube to make sure that there is no pathology. You give a little bit of steroids, typically 4 to 6 dexamethasone for a couple of days and wait. These are the options.
Great. So I would suggest just go to Dr. Kennedy, still that we have lots of questions. So we go for the next presentation now, and then we will continue answering the questions afterwards, if it's fine with everyone. Okay. Thank you, Doctor.
Thank you. Thank you.
Dr. Kennedy, are you with us? Sorry for the delay.
Absolutely. No problem. Thank you. That was a great talk. I learned a lot. Thank you. So I'm just going to share my screen. So screen sharing. So we're going to, I guess, change track slightly and focus on single-use bronchoscopes. So can you see this now? Can you see the images? Yeah,
Yes.
perfect. Okay. So I'm a physician from Cork, Ireland. I am now an interventional pulmonologist. So basically, I'm a plumber. I remove blockages, usually malignant, but also benign. I removed a P from someone's airway today. And I trained in ICU as well. I trained in the States and I worked as an ICU consultant there. But on return to Ireland, anesthetics really managed both the intensive care unit and the theatre. So I was looking at a picture of Ria as the previous during the previous talk, and this is a picture just from outside my window right now where I'm giving the presentation. Very similar. It's 40 degrees Celsius, I believe, in Ria now. It's 14 degrees Celsius here in Cork. I also, because the temperature was so hot in Ria, I decided to see how long away it is. So it's 74 hours drive, 6,200 kilometers. And this is the map of how you would drive if you're tempted to drive up to some cooler temperatures or warmer temperatures down here. But of course, the price of petrol in Ireland at the moment is very high, so I don't think I'll drive. Disclosures, I've received fees from Pentax and have contributed to some of their publications. And for Boston Scientific, I have some research protocols being, I guess, processed speaker fees. And from the surgery company, I've had speaker fees and I've received equipment for research. And from Cook Medical, I had a train and research grant. So those companies will be mentioned during this talk. And I was involved in a cost-effective analysis with Ambu. So this talk, I guess, is relevant to respiratory physicians, to critical care doctors, to anesthesiologists, and to cardiothoracic surgeons, because we now are kind of faced with questions around do we switch to single-use flexible bronchoscopes? What one should we switch to? And these really were pushed on. I mean, the decision process was really magnified during COVID, as you know. So I cover cleaning of bronchoscopes, risk of infection from standard bronchoscopes, risk of infection in the COVID era, the types of single-use scopes, advantages, efficacy, cost, and some research from our hospital. And the question is, are these scopes ready for prime time? So as regards cleaning of bronchoscopes and in general cleaning of devices, so the Spalding classification looks at the cleaning of medical devices in general. And actually, endoscopy and bronchoscopy is considered a critical device and should be sterilized, but we don't sterilize bronchoscopes. And reasons are bronchoscopes really don't survive sterilization. So we do high-level disinfection. And there's a lot of steps to scope cleaning. So they're pre-cleaned. Once you use a bronchoscope, they should be pre-cleaned at the site with a brush going through the scope. Then they need to be transported over for leak testing. So that makes sure you haven't damaged the scope, looking for a leak. Then they need to be manually cleaned. And then they're usually cleaned in a high-level disinfection machine as such, and rinsed. Then they're inspected for damage. They're stored. It's important to store them in the correct temperature and location. Then they're brought back for use and cleaning again. And it's important that they're not stored in a location where GI scopes are present. So why aren't they autoclaved or sterilized? Well, the chemicals used would damage the scope and they're expensive. And they're not suitable for autoclaving. The proximal part that plugs into your processor is not suitable. So high-level disinfection, it does eliminate bacteria, viruses, and fungi, we think. It should, but bacterial spores are resistant. Prion disease are resistant. It depends on adherence to protocols, and we don't really know about COVID. There was one publication, a letter, wondering whether COVID virus would be resistant to high-level disinfection. So the ECRI is the Emergency Care Research Institute. It's a global independent organization that looks at safety and quality across all healthcare settings, and they bring out a top 10 list of important risks to our patients, and the contamination of flexible endoscopes due to mishandling and improper storage was in the top 10 and 29, and they referred particularly to recontamination of disinfected endoscopes. So this is a patient I had actually about 4 weeks ago. So on the left was the CT scan, on the right, so lung images on the right, you might see just going into the left main bronchus, there's sort of tissue surrounding the left main bronchus, so some peribronchial swelling. And this was a tumor. So an outside hospital went on with standard bronchoscopy, didn't see anything in the airway, referred over to me for endobronchial ultrasound. And before he came to me, he actually developed a right upper lobe pneumonia. So this was about 48 hours after the standard bronchoscopy. So this infection was related to the procedure. The question is, did this infection come from the scope? Of course, we put the scope through the mouth, and did it come from that area? But regardless, this infection was related to standard bronchoscopy. So this image looks at, or this table looks at all the papers that I've looked at infection related to standard bronchoscopes, and overall the infection rate is somewhere around 2.8%. So that's significantly high for bronchoscopy. You know, that's the infections we know. There has been studies of old that looked at CRPs, white cell count, temperatures after bronchoscopy, but they haven't really been repeated with better I guess markers of infection, and it's something we need to do. So after a reasonable bronchoscope, we really need again to look at the patient 1 to 7 days after the procedure to see how common infections are. This was a very important seminal paper published in the last 3 or 4 years. So this was the effectiveness of essentially cleaning bronchoscopes and ultrasound scopes. And this was in 3 tertiary referral centers in New York City. So not small centers, large centers, including 2 transplant centers. And they assessed 24 bronchoscopy procedures, including EBUS. And this included observation of the cleaning, high-level disinfection, inspection for scope damage. And they actually used small scopes called boroscopes to fit down regular scopes. So they looked inside the channel of a bronchoscope, and they checked in there for infection, for protein, hemoglobin, and ATP. And the results were profound. And what they found was all scopes had residual contamination, human DNA and protein. So that's a scope that you're going to put into a patient, be it your critical care patient, your patient in theatre. 100% of the time, these scopes had someone else's DNA and protein in them. I know if I was consenting my patients today and actually mentioned that, the majority of patients would refuse to have the procedure. So it's a significant issue. In 55% of those scopes, there was organisms that could cause infection, like Stenotrophomonas, which is a big issue in our cystic fibrosis patients here. All scopes had other visible irregularities, including trauma. And reprocessing practice were substandard in 2 of these centers. And these are large academic tertiary referral centers, including transplant centers. So it's unclear at this point what the contribution of these findings are to conversion to infection and fever. However, these findings are concerning. They did not check for mycobacteria, fungus, virus. So there's a colleague of mine, a cystic fibrosis doctor, going to look at this question. So he's going to take samples and really look with the genetics for these other organisms. Even standard cleaning practices recommended by manufacturers were not good enough. And the reduction in size of scopes we have, and newer devices such as endobronchial ultrasound scopes, make cleaning more complicated. So as you reduce the size of scopes, as we're going more out to the periphery to sample lesions, there's going to be more issues. But prospective trials are required. So this shows an endobronchial EBUS scope. You can see a crack in it, and that's where filaments of bacteria might be located. This is a standard bronchoscope. So the inside of a standard bronchoscope, the diagram number A, or picture number A, is normal. Picture number B, there's dents in the scope leading to swelling. In number C, there's residual fluid in the scope after cleaning it. And number D, you can see some filamentous debris inside the scope. So these are after cleaning. So this is a significant concern. And this shows the sites and how adherent the sites were to the protocols. As you see, there's the sites B and C were not adherent. So thus, the single-use bronchoscopes have been developed. So this is the Boston single-use scope. This is just images from inside my office with a standard mannequin. So the scope comes with its own a screen or monitor, and these screens can be cleaned. So the companies don't allow you to plug the scope into, for instance, a laptop. because you can't clean a laptop down. And the temptation would be to do more procedures outside the hospital even. So they come with a standard monitor, can be cleaned down. And for instance, the Boston Scientific monitor can be plugged into your monitors that you might have in your endoscopy unit. Or you can just look at the image through this portable monitor. So there's 5 commercially available single-use bronchoscopes at the moment. You've got on top the surgery company scope, you've got the Boston Scientific, the second one, you've got a Vatin scope, the third one, Pentax is the next one, which is not commercially available as yet, and Ambu, the one that you all are probably more used to, was the first scope that was released. And this is just some evidence of efficacy. Most of these are currently available efficacy studies are based on the Ambu scope, which was the first scope used, our first scope developed. So in elective surgery, in ENT surgery, and just in the third column, which is samples collected for research, be it orotracheal intubation in an anesthetized patient, be it tracheal intubation in wake patients in ENT, or just BLN collection, they're adequate. In general, the physicians and anesthetists are happy with them. However, sometimes the images weren't good enough. But for basic procedures such as intubation, they appear to be equivalent to reusable scopes. This is a more recent study looking at an ICU and a tertiary referral, SUFB, and 20 reusable, and it was found that these were equivalent according to the critical care doctors. This is a larger study now, again with Ambu, and now these scopes are being used by pulmonary services. So they started off, I guess, in the ICU and theatre, but now respiratory physicians are using them more and more. So this again was Ambu, a cross-sectional study in Spain. 300 procedures, the majority were just bronchial washing or lavage. They just took biopsies in 3%, 94% satisfaction in general. So more and more data. Cost obviously is something that we question. So these are the visible costs related to the bronchoscope. So you've got the purchase cost of a reusable bronchoscope, but then there's other costs, the part of the iceberg you don't see. So you've got repair costs, consumable costs, time spent cleaning, and also potential cross-contamination costs. So this is just you can look at this online. So this is a calculator that will allow you to calculate what the cost of each reusable scope procedure is. So you can vary at the top the price of the scope. You can look at the number of scopes you have in-house. So let's say the scope costs $21,000 or $22,000. Let's say you have 6 of them in the hospital. There's a maintenance contract with these scopes, somewhere about $3,000. You got to purchase the video processor and light source. You got to purchase storage equipment. You got to purchase disinfection equipment. The maintenance storage per year and disinfection equipment per year. Scopes depreciate over time. The time that staff spend cleaning them, the hourly cost of your staff, and you can get it then a calculation of how much each procedure costs. So then in this case, if you did it at 300 procedures a year, the cost of using a reusable scope is $261. However, if you add in cross-contamination, it's $554 per patient with the risk of infection. So that kind of allows you a look in general at what cost is. So this table looks at the cost effectiveness of single-use bronchoscopes. So the first column, the setting was in theatre, retrospective study. They looked at initial outlay, storage, and cleaning, and they concluded at a procedure frequency of up to 200 procedures, it was more useful to use single-use scopes. So naturally, the more you use the reusable scope per year, the more cost-effective it is to use the reusable scope. However, these authors did not look at the risk of infection, and they did not do enough analysis of the other costs of reusable scopes. The next column was better. This was a micro-costing analysis, so much more in-depth analysis. of single-use versus reusable scopes. And they incorporated the cost of that 2.8% infection risk. And they found that single-use bronchoscopes are more cost-effective owing to the elimination of that risk. The next column looks at in ICU in a university hospital. Just to move on, that their conclusion was it depended on the procedure performed and the number of procedures per year. The final one actually looked at in the environmental impact as well. So we'll come back to that in a minute, but these are disposable devices. But what they found was that the environmental impact of a reusable scope is significant, be it the chemicals to clean it, the PPE and so on and so forth. And they found that the cost to the carbon footprint was similar. Okay, so I just want to move through this. I've kind of gone through that already. So we've done some research on these scopes in our centre. And the first research that we did was a clinical trial of this. This was the first scope available to us, which was the surgical company BronchoFlex scope. So we did a clinical trial on this, prospectively 139 patients, 5 pulmonary faculty from January to July 2021, so during the COVID pandemic. And that's really what brought this into our practice. The majority were carried out for infection, malignancy 32%. Most were performed in endoscopy suite. However, some were performed outside the suite, for instance, with patients with COVID or in the ICU, and 8% were COVID positive. This was the indications: infection, malignancy, asthma, interstitial lung disease. These are the procedures. So we did more procedures than the previous Spanish study. So we did endobronchial biopsies, brushings, transbronchial biopsies, some argon plasma or electrocautery cryobiopsies, and a tracheal stent. So one issue with this scope is that, I just showed the video here, the tubing kinks coming from the suction port, which goes superior in the scope, and then you put on the lavage trap, and the lavage trap hangs down, so that the tubing between the lavage trap and the scope kinks. So you can see in this image, our respiratory fellow or registrar is kind of holding the tubing come out of the trap in a loop to stop kinking of the tube between the trap and the scope. And people aren't aware of this, and they're wondering why their lavage is not good enough. The company put the suction port superiorly right through the scope to try and improve suction, but it didn't really work. The other factor of this scope is you have to remove the little cap off your valve to put devices through, just to be aware of that. And, you know, this is a fracture I had with this scope as regards the suction cap. Complications, we did have complications. They're either reported with the scopes, such as the suction being inadequate from that kinking, the scope breaking, or also an inadequate image. So a lot of our faculty found the image not satisfactory. And this monitor at the moment doesn't plug into your larger endoscopy screens, but their newer iterative of the monitor does now. And overall, in general, satisfaction was at the top rating in 83%. We just use a Likert scale. You can see the top left here, not satisfied to very satisfied. So mostly we were satisfied with the scopes. So just a few things that we did. Hope the videos are working okay. So this is just an endobronchial biopsy using this scope. Then next we have a cryobiopsy, I think. Yeah, so this is a cryobiopsy just to get a larger endobronchial sample for analysis. So it works just fine for all this. We did some argon plasma coagulation. Now the scopes are not licensed for electrocauteries yet, but you know, I was able to do it. And finally, this is a patient where I was moving a Boston Scientific stent, an Ultraflex stent in the left main bronchus, and you can see another stent invading through from the esophagus. This patient had obviously an advanced tumor with a bronchopleural fistula, so I'm just blocking the airway as well to try to reduce aspiration. So again, the scopes are available. So the Boston scope I've been using now more, and I do like this scope, and you'll see the reason why in a minute. So I've collected just 24 cases so far. Usually, most of them were their larger 2.8 scope, and I go through the sizes. I've no complication at the moment. 23 out of 24 top satisfaction score. One case I was unable to access the right upper lobe with the forceps out, but I'll show you that's not uncommon at the moment. So what I like about this scope is the suctions. This is through a rigid bronchoscope. This is just suctioning out some blood in a tumor in the right main bronchus. So I like the suction of this, and I'll show you why in a minute. This is just taking a biopsy, and you'll see with the device out, when I take the biopsy, I can suction with the device. So the forceps is there, so I can go down and suction the secretions and so on and so forth with the forceps in. And then this is just an image of, I use the scope actually to move through the tumor, so it's solid enough that I can use it kind of to debulk and create an airway through that tumor. So let's say you're a believer now in these scopes. So which one is best? So I did some benchtop and technical analysis of these 5 scopes. So just the table here just summarizes some features of the scopes, and the ones we assessed were the scope from each company. So Ambu, Boston Scientific, the surgical company Bronchoflex, Pentax, and Vatten. So these are the 5 available at the moment. So most of our testing was a similar size channel, the 2.8 channel, which is the larger channel. Just going through the rows here, the length is the same. The Vatten scope is a bit heavier. I'll come through these measurements we made in a moment and what they mean. One of the scopes is rotatable. That's the Vatten scope. The Boston scope locks out after 12 hours. That means you can't use the scope anymore, but you shouldn't be using the scope after using. These are not reusable scopes. These are single-use scopes. I'll show you this balloon issue in a minute. Actually, I'll just show you now. So this is I don't know, you know, this Cook Arndt balloon blocker. You might use this in patients who have hemoptysis, and it's got a little lasso you put around the scope. The lasso slides off the surgery company scope, which is a disadvantage. It does fix to the other scopes. There are different sizes available. So you can see most of the scopes have these are the other sizes available. So they usually have a large and maybe a small for pediatrics and a middle-sized scope. And the Vatten has more sizes available. The monitors are now, they're all high definition. They have different compatibilities and what you can plug into. Okay, so benchtop. So what I wanted to figure out was flexion and extension with these scopes. So these are relevant to me when I'm trying to get into the upper lobe and so on and so forth. But this was a study I did before on reusable scopes, looking at what happens when you stick the forceps out. So you can see in the middle image here, there's a loss of angulation when you stick the forceps out. And the companies don't really report this, but this is relevant clinically. The bottom image is of an endobronchial ultrasound procedure. So on the left, you can see the lymph node. But on the right, when you put the needle out, the scope extends back and you can't see the lymph node anymore when you're biopsying, for instance. So what we did was we test these benchtop, looking at flexion and extension. And what we found was, these are the total angles from flexion to extension. So total flexion, total extension of the tip. So the Vatten scope had the highest flexion to extension. And you can see but there's significant loss once you get the forceps out. So you can see in the second column, you can see how the losses in flexion and extension with the forceps out. So Vatten still preserved, a good flexion extension. The Boston had the least, very little loss, and it actually there's not much difference between flexion extension with and without the device out. The Ambu and the Pentax really lose their, I would say, and Bronchoflex have poor flexion extension with the forceps out, and that's important to us when we're trying to get into certain areas. So another test we did was we looked at kind of this preclinical test, looking at trying to navigate a scope down through this simple model and taking a biopsy. Now, there was no suction with this, and there was no image looked at. So the people that we tested just came in, tried to drive these 5 scopes down through this model and take a biopsy. We used Likert scales again to evaluate, and we evaluated ergonomics, comfort, ease of technical procedures, and overall impression. Total maximum score 55. So this table just shows who we looked at. We looked at, a lot of different healthcare providers, including anesthetists, including respiratory docs, nurses, gastroenterologists, surgeons, and so on and so forth. And overall, this is the overall impression. So the column on the right, the mean score for each scope, And people in general liked the surgery company scope, and they liked the Pentax scope, and they didn't like Ambu. That's the most important thing. So if you just put these scopes in people's hands, they don't really like Ambu. Now, again, this doesn't have suction on board, and this doesn't look at the image. This is simply when you put the scope in people's hands, what do they think? To break that down a little bit more, I looked at respiratory faculty and fellows, and I looked at the anaesthetists. So again, respiratory didn't like Ambu, and anaesthetists didn't really like Ambu. They preferred the surgery company scope, and the rest of them were much of a muchness, they thought. So they folks don't like the Ambu scope. We looked at other factors, including gender, and females tended to prefer the Pentax scope. Males prefer the surgery company scope, and there's a reason for that. If you had a smaller hand, you kind of prefer the Pentax scope. So females typically have smaller hands, and that comes down to the measurements we did here of various different measurements as regards the handle size. So that was just putting the scopes into people's hands. As I said, people didn't like the Ambu scope, especially the respiratory docs and the critical care docs. However, this was the game changer for me. This is a measurement of suction. So I wanted to figure out which of these scopes were better with suction. I was kind of getting the impression that the Boston Scientific scope was better for suction. And this is key for all of us. This is key for critical care doctors when they're trying to suction out mucus plugs and so on and so forth. This is key for cardiothoracic surgeons with blood in the area. This is key for me when I'm trying to suction out blood, whatever. So to do this, we got some guar gum, and we made mucus. So this is looking at different concentrations of guar gum to saline, and it's kind of a pseudo mucus, as you can see. And we tested the 5 scopes. So this is we had 2 scopes from each company, and this is so scope 1 and scope 2. And the different companies are in different colors, okay? And first of all, we checked saline 50 cc's and saline with a forceps out. And then we checked the guar gum, just 20 cc's because it was slower, and the guar gum with the forceps out. And we timed each scope as regards how long would we suction this up. And the red line is Boston. And I was amazed that it was doubly as fast as across the board. As you can see, the red line. And even we have in here a reusable 3.2 Pentax bronchoscope. So that's the orange color scope. So that's a reusable 3.2. The others were 2.8s. So right across the board, either mucus around a device, the rest of them couldn't even do it. And this was significant right across the board. So the reason for this is the way the Boston Scientific scope is designed. It's got, as you can see, grooves along the rounded channel, which allows suction around it, but also the proximal in the scope. There's a better proximal channel in the scope handle to get through to your suction. So for me, this is very important for what I do. So this is a transbronchial lung biopsy. We're putting the biopsy out distally. This patient's had a right middle lobe lobectomy. That's the stump on the left. We're just looking for, and we took a forceps biopsy. It's bleeding well into suction this blood and deal with it with a 2.8 channel. There was no issue here. It was suctioned out, maintain the airway, and sort the issue out. Again, forceps out, tumor, taking a biopsy, 2.8 channel, Boston scope, biopsy, bleeding, able to suction the blood around the biopsy forceps. So that's very important. So just to summarize, to go through each scope, so the Ambu scope has the most data. The data is ICU. It's got a reasonable size range. In handling, it ranked 5, so that was the least best in preference. Flexion extension ranked 5. With the device in, it ranked 4, and suction, I'm going to average the suction at 2+ for all these. Next, we have and Ambu have actually, they're aware of this, and they've made a 4th generation scope, trying to make it look more like a bronchoscope, trying to satisfy the respiratory physicians, but this is just released. As regards the next, sorry, I can't see the top of this because I've got the bronchoflex scope. Very little data other than ours. Male preference, and folks liked it when it was just put in their hands. Flexion extension was reasonable. Suction, very little data. Pentax, no data at all on this scope. It's got a poor size range. Small handed females prefer that. The Vatlin scope is a good size range, it's good flexion and extension, no data, but the Boston, for me, the big thing is suction here, and that's critical for me. It's got good flexion extension, but the critical thing for me is the suction. So, just in conclusion, the Vatlin scope is the biggest range of tip movement from flexion to extension with about forceps. Females preferred Pentax, males preferred the surgeon company, just when you put it in their hands, without suction, without the screen. Respiratory physicians ranked Ambu significantly lower, as did anaesthetist, but Boston outperformed all the others, including the standard Pentax scope as regards suction. So just finally, I have a picture of Ed Sheeran here, the singer. So during lockdown, he made a crib for his child. During lockdown, I made a low fidelity simulator. You can see there's toilet paper here. It allows pliability and Play-Doh. And just we use this to train. So these single-use bronchoscopes are great for training. You can bring them into whatever environment you want. And this is just a physician doing a brushing. And here's just an endoscopic image of a brush going out. So great for training. And then this is another doc doing a biopsy of a pseudo tumor with the Play-Doh, child Play-Doh. And what we found that was right across the board, we could train people. So just in conclusion, advantages of these scope, this is a review paper that we published. Bronchoscopy in the ICU, fantastic. In the emergency department or the ward, yes, easy mobility. Outside the healthcare facility, you can bronchoscope if needs be. Out of hours bronchoscopy, so you don't need anyone to clean the scopes. End of the day list from the staff, where staff are not required. Weekend bronchoscopy, bronchoscope available for inspection during an EBUS procedure. Immunocompromised patients, the prion disease where scope would have to be destroyed. Bronchoscopic training, veterinary procedures, large animal research. So all available there. Disadvantages, there's very little data so far. They're not recyclable. Staff may lose their jobs because they're not cleaning. The screen size needs to be improved, a lot of them. You can't reuse these as a temptation. The portability may lead to more procedures outside the endoscopy where standards care might not be as good. So that's a disadvantage of portability, not licensed for electric cautery. Finally, this is just a few procedures with these scopes have been used outside respiratory, off license. So this is to get into a bile duct. This is actually a pleuroscopy with the bronchoscope. So are they ready for prime time? I'd say they are good concepts. This is what a prime time program needs. There's audience comfort, there's room to grow, good writers and actors, loyal network, and we don't have to deal with the public's fickle taste. So finally, this is off license again, the Boston Scientific Scope, just doing some electric cautery with this. Again, off license, but it is feasible to do argon plasma with this. So thank you. I'll finish there. Thank you.
Thank you, Dr. Kennedy, for your presentation. I had good insights from it, so I made some notes. I really liked the way that you did the testing in your department, and it's really impressive. I actually had a question to Dr. Labib, since I see in your presentation for difficult airway management, you're mostly using video laryngoscopes. Is that correct? Do you ever use bronchoscopes, either reusable or single use? For
intubation purpose?
Yeah.
It's I don't think it's for
needed.
critical patients. It's less practical, I would say. For the elective intubation, it has its established role. But practically speaking, if you have a sick patient on the medical floor or the surgical floor or in the ED, the preparation time for awake fiber optic intubation adds to the challenging situation. It has its role, yes, it has its role. If the patient already has a tracheostomy, and I'm sure Marcus would agree with that. The fiber optic has a place in airway management, but not for the intubation process itself. Maybe after you intubate, of course you do. Maybe if you have a tracheostomy in place, that you are a little bit unsure where it is it blocked, is it partially beta and dislodged? Yes, it does. If you have a patient who's bleeding, it does. But for the purpose of intubation itself, I don't think it has established role at the moment. Maybe in future, maybe it will have a role.
Okay, thank you. Yeah, good for me to understand it as well. As we are currently new in the ICU field as Boston Scientific, so we are learning while doing. So it's good to understand like whether it's a good fit. Let me check. So we have Salima Alamri raised her hand. So if you could just unmute yourself, because I can't do it for you, that would be good. I'm just checking if we have any questions in the chat. I saw that we don't so far. And we are obviously just a bit over time. So thank you all for still staying with us during this evening. So if there are no more questions, then we kind of can close this session. Again, thank you, our speakers. Thank you, Dr. Kennedy, Dr. Labib, for your great presentations. I personally learned a lot, and I'm sure that our attendees did it as well. So in case if you have any questions, you can always contact me afterwards, and I would be able to transfer questions to speakers. We have one new message. Thank you all. Thanks a million. Okay, so hopefully everyone was happy. Have a great evening and enjoy the rest of your day.
Dr. Kennedy, it was a pleasure to listen to your fantastic talk. Thank you so much.
You're more than welcome. And you too. Thank you.
Thank you.
That's great. Thank you.
Thank you. Take care. Bye-bye.
Bye.